Good evening again, everybody. I'll just turn up my volume. Can you hear me?
Yes.
I'm going to hand over straight away to Rachel, actually, who's kindly going to facilitate the session tonight. So, and just a welcome to any newcomers. I see Janthi's joined us, so welcome, Janthi and Crystal. Hopefully, we'll have some more people joining us as we go on.
Thanks very much, Odette. Welcome, everybody. Can you hear me all right? I'll be handing back to you, Odette, in about 30 seconds. So my name is Rachel Coughlin. I'm a palliative care physiotherapist based in Melbourne and a researcher on palliative care in humanitarian crises. And I'm on the executive group of Australasian Palliative Link International, which is how I come to be here. So great to have you for this 5th session, which we've already heard is focusing on quality improvement in palliative care. The way this evening's session will run is that we're going to have an overview on quality improvement from Odette, and then we'll have 3 presentations from our Indian colleagues about their specific experiences and involvement in quality improvement projects. All of those Indian sites have participated in an international quality improvement mentoring program called PC PACE, the Palliative Care Promoting Access and Improvement of the Cancer Experience project. A project which I'm sure Odette and the others will explain, but one which initially came out of Stanford University and then out of Tata Trust in Mumbai. It's a project that started in 2018 across 7 sites with mentorship from colleagues from both the USA and Australia. And in keeping with the train the trainer model that we use also with Project Hamrahi and APLI, several of those who were initially involved in the PC PACE project have gone on to become mentors themselves, including 2 of our presenters here this evening. So given we always seem to run over time because we like to talk and engage in discussion, I won't say anything more, but I'll hand over to you, Odette, and I don't think you need any introduction. Thanks very much.
Thank you very much, Rachel, and it's lovely to see old friends again on the Zoom. Hello, Anjum. I think this might be your first time joining us, so it's great to see you. And as I mentioned, there are a couple of newcomers as well from Australia, Crystal and Janthi and Tara, who's joining us, who's based here in Australia at the moment, but originally from Bhutan. So I think I think at the moment the group that's on the call are we're sort of the presenters are familiar with the PC PACE program, but hopefully we'll be joined by a few more of this Hamrahi ECHO program participants who have been part of it since in previous months, so that they can hear about your presentations. So I might, Shri or Raju, I might ask if you share the slides. We're thinking that it might work better if we've had a few technical hitches on previous sessions. So we're going to.
No worries, ma'am. We will share about it.
If you start sharing, that'd be great. Thanks.
Sure.
So I thought I would just provide a quick overview about the PC PACE program, now called the EQUIP program, and some of the principles of quality improvement. And then these will be shown to you in each of the presentations that our 3 presenters are going to be doing. And so you'll hear a lot more about these, particularly the tools of quality improvement. And then also there's some reflections, I guess, on what works and what doesn't work in terms of sustainability. So next slide, please. So why do we do quality improvement? And I guess we all probably have a mindset that we can always improve our care. And there are so many aspects of our care that we can work to improve. I've just picked a couple of little stories. For example, this patient that we met on a ward round, and it was actually another patient in the room who said to us, they keep calling him Danny, when the patient's name was actually Edward. And it was an elderly man who was delirious, had newly diagnosed cancer with bony metastases, a urinary tract infection, was incredibly vulnerable, but it really took another patient to kind of point out that the staff were not calling this already confused man by his own name. And another occasion when I was in India, actually, a young physics student said to me, "You're the first person to say my name, say my name correctly in the 10 days I've been here." Now, these are small things, but this is one aspect of our care. The more qualitative component of our care that we can, how do we best deliver care in a way that retains the patient's dignity, that we can look at, and some big quality improvement programs have come out of that. There was a whole program about My Name Is, so that staff would introduce themselves, and that's become a major quality improvement thing and activity internationally. And so we can look at those more qualitative aspects of our care, but we can also look at ways that how can we improve the patient experience through more coordinated, efficient, and timely care. And I think providing or improving care is often looked at as sort of an individual responsibility, but I think what quality improvement programs help us to do is to look at the organizational culture that places value on improving quality, and recognizing that it's an organizational and often a cultural problem that is contributing to poor care. And often the staff behavior is just the tip of the iceberg. Can we have the next slide, please? So this PC PACE program, PC PACE stands for Palliative Care Promoting Assessment and Improvement of the Cancer Experience, and which later evolved into the EQUIP program, which stands for Enable Quality, Improve Patient Care India. This all began in 2017, actually at the Indian Association for Palliative Care Conference in Coimbatore. Professor Carl Lorenz from Stanford Palliative Care Service was one of the keynote speakers. And while at the conference, he had conversations with palliative care leaders in India, Dr. Sushma Bhatnagar and Nandini Balath, amongst others. And this idea of an international quality improvement program came about. Stanford has an amazing quality improvement program and leaders in quality improvement and organizational change and improvement, in particular Jake Mickeltham and Michelle De Natale. And then it's also Carl was very passionate about improving quality at an organizational level. So the idea, in essence, was to identify palliative care programs in India that were leading programs, and have coaches from peer institutions in the States and in Australia. So there were 3 institutions in Australia that were involved, including the Peter McCallum, where I was involved, and then Dr. Mira Agar in Sydney and Karen Anderson in Perth. So along with other coaches in the US. And I'll show you in the next slide how the program was actually structured, but just how this all evolved over the last few years then was that after that first cohort in 2017-18, the next cohort actually was led by the Tata Trust in association with the National Cancer Grid India, and a second cohort of 7 sites was worked through. And then in 2019, the whole program transitioned to being fully run out of Mumbai. The name became Equip India, and it expanded to palliative and oncology services. Same sort of methodology, but by this stage, there was more of a sort of culturally nuanced structure and content and evaluation, and also national mentoring alongside with national mentors such as Vidya and Sunil, alongside international mentors. So it's been a nice transition from a externally led program to becoming a program led in India. Next slide. So the principles are that each site, now I think sites in India actually apply to be on the program, and each site that enters the program identifies a particular quality improvement project that they'd like to do, and all the sites meet together. In the past, it was monthly. I think in the upcoming cohort, it's going to be slightly changed, but essentially a monthly so-called all-hands meeting, which would involve some didactic teaching about some of the tools that we're going to hear about and see from our presenters, how to actually go through the quality improvement processes, and then opportunities for sites to present where they're up to in their project, and also ask questions and get some peer-to-peer discussion and education going. And in the intervening weeks, the mentors and sites progress their projects and connect through email or other WhatsApp or other means to try and brainstorm and overcome any obstacles and keep the momentum going. And it all culminates in a graduation ceremony. Alongside this, there's been an evaluation of the program with a grant through ASCO, which has led to some publications about the program. So it's fairly intensive. Next slide. I now just want to talk about the A3 approach to quality improvement, which is the one that is adopted by the Stanford Quality Improvement Department. Essentially, the A3 is literally an A3 piece of paper on the which condenses all the steps that are involved in conducting a particular project. So on the right side there, you can see how things currently are on this part of the A3, and then on the left-hand side are some of the efforts that the teams would take to try and improve the processes. So in a sense, how we'll work together to get where we would like to be. So next slide. So on the right side of the A3, the focus is on identifying the problem and defining the SMART goal, on analysing the current practices that are in place and conducting so-called root cause analyses, and on mapping the current practice and starting what's called the run chart. Next slide. So in more detail, you need to sort of click on this. I've got, could you click, and it'll take us through some of the details. So at the top, we've got the project title. What are we trying to improve? Then we have who is the team, and identifying and forming a team is a really critical aspect of the whole process. Next click. So the problem statement is as what are we trying to solve, and it's a what is happening, not a why. Very important in this right side of the QI process of the A3 is to avoid assumptions. Robert Twycross very fond of using that little saying that to assume is to make an ass of you and me, and that really applies in quality improvement, that we're trying not to assume that we know why things are not working as well as we would like. We're trying to really start from scratch and really look at what's happening, and not sort of jump to solutions too quickly. Next click. So the background here, it's useful just to explain why we've chosen this problem out of all the many things that we might have chosen to try and improve. And then the next click is looking at what is the SMART goal that we're going to adopt for the program, for the project. So a SMART goal, many of you will be familiar with this, I think. SMART stands for that the goal is specific, that it's measurable, that it's achievable in the time frame that we've got, that it's relevant, and that it's that we set ourselves a time frame that we want to work within. And you'll hear some good SMART goals in the presentations later. Next. So then we come to the root cause analysis, and there are some tools. This one is known as the fishbone diagram or the Ishikawa diagram. I'll show you that larger in a minute on the next couple of slides. The next click is, this is called a Pareto chart, where with the data that you're collecting in the root cause analysis, you're identifying what are the activities or events or things that the teams are doing that are contributing the most to the outcomes that you're seeing. Next click, we have the run chart. So this is the way of graphing each of the activities that you're monitoring, and then also the interventions that you implement and the date that they're implemented, and trying to show that you're reaching or see whether you're reaching the target that you are aiming to get to, this green line here. Next slide, next click. Then we come to the left side where we have initially the first column is the key drivers. Can you keep clicking? Next click. So these are things that need to happen consistently, keep clicking, or structures that should be in place in order to reach our goals. And they're not, it's not the same as the interventions that, yeah, keep going, that we're going to identify and test. So the interventions are the actual changes that we make to our processes that result in our key drivers occurring in a consistent basis. And then moving on down, so the next part of the A3 is to look at how are we sustaining? Can you just keep clicking? Sustaining the process that we and the activities that we have chosen to do. And there are different reliability measures. So we can include here, you can see reliability level individuals, procedures, or systems. And you can see here in the interventions where you've got in brackets 1, and then the person who is made responsible for maintaining that particular intervention. And so the 1 refers to the reliability of that particular intervention, because reliability relates to how likely it is that that intervention will be sustained and will be able to be continued when the project time itself is over. That it's, and generally it's the interventions that are rated at level 3, where you're really changing at a very core level how a care is delivered, that are the ones that are likely to be sustained. And then in the PC PACE program, each month the teams would evaluate just how far they have progressed on each of these interventions with the aim of really tracking progress. Next slide. So that's the A3 that summarizes the whole process in one sheet. And this was the fishbone diagram. So it's generally the headings are what are methods, materials, people, measurements, machines, and environment. And different projects, some of these may be relevant, some may not, but those are the most commonly considered sort of major areas. And then within each of those, looking at what are the methods in place, what are the materials, or where are the lack, what's the lack, you know, some places may just not have enough computers and therefore may not have here enough staff to capture data or to make appointments efficiently, or so trying to break down the different components that might be contributing to a problem. Next slide. And here the Pareto chart is just a way of collecting data that is aimed to determine which events or activities have the highest frequency and so may have the greatest impact on the outcome. Because of course, addressing the most common issues is likely to have the most chance of improving the outcome. There's a quote about Pareto that if you have Noah in the ark and it's sinking, then you're more likely to solve the problem if you get rid of the elephant than if you throw away the rats or the lighter animals. So you're trying to identify what is the major component to help you then determine which key drivers and which interventions you may focus on. Next slide. Another tool is called the 5 whys. And here you just keep asking the question why. For example, if you're trying to improve the waiting times for patients going to radiotherapy, as in this example, then you may say, okay, there's a long delay between patient entry and the radiotherapy session. And then you say, why? Because they don't know their requirements for day 1 of their radiotherapy. And why is that? Because they don't read the information. And why is that? Because they can't find the appropriate section of the pamphlet. And why is that? Because the pamphlet's too difficult. So it's, you know, you may not need to go 5 whys, but the point is to really try to drill down to a deeper understanding of what the problem is. And next slide. And so all the root cause analysis tools are trying to help work out the major contributors to a problem, and so that you can identify the best interventions. Next slide. And then the run chart tries to graphically capture any the baseline practices. So here, the red line here is the average baseline bed utilization rate for this project conducted by one of the teams last year, a cancer center, trying to improve bed utilization rate for chemotherapy. And then here they introduced various interventions and then tried to assess the impact of each intervention on their bed utilization rates to try and reach their target, which is this green line. And they also include events that caused problems and delays. And so that when you look at this graph, you get a good sense of the whole process and way their project was carried out. So, and last slide, in summary, we've talked briefly about some of the measures and the A3 form and the A3 approach. There are other approaches to quality improvement, but this one, to me, I've found it very useful way of summarizing and condensing and demonstrating a quality improvement program from start to finish. And hopefully that gives you a little bit of a sense of what the PC PACE program is all about. I think for people in India, not all the sites would have heard about it, I suspect. So I'm sure Vidya and others will be able to tell you more about how to get involved in it if you're interested in doing that in the coming years. It does seem to be likely that the program will be sustained, from what I can tell from a distance. So that's all I have to say, and I'll hand over to you, Rachel.
Thanks very much, Odette. Great overview, especially for a rookie PC PACE Equip India person like myself. I might be one of the only ones on the call who needed a 101 overview, so that's fantastic. Does anyone, before we move on to our Indian presenters, does anyone have any questions or comments for Odette at this point? I've got a question. Odette, with the A3 tool, if a project hasn't reached its goal within the measured time frame that is specified, do they just keep going, or do they then re-look at the entire project and its issues and interventions and do the A3 tool again?
Well, good question. For this piece Equip program, you know, there's a discrete time frame, and there's a lot of input to try and assist participating sites to keep on track month by month with each step that they are supposed to be at for that month. There have been sites who have significantly changed their project along the way when it was clear that it wasn't quite, well, sometimes they've had to change their SMART goal because it wasn't achievable in the time frame, or it was not specific enough. But sometimes that only becomes apparent as you progress on and you do some analysis and you realize you've started at too high a level, and you have to sort of define your goal a lot more clearly. But I think in general, though, when we're working in, it's probably a good idea that time frame is probably important to any quality improvement, whether it's on a quick program, or because the longer it sort of drags on, the more likely people are to lose interest along the way. So I think if you're finding you're not able to achieve your goal, then I think it probably does need a relook and perhaps a new start. Would you like to comment on that, Vidya, from your experience?
Thank you, Odette. Thank you for that question. I think that's why the last part of the A3, we also have an abandoned place. You know, maybe that particular approach didn't work. So that is also learning. So the learning is also in what didn't work. So, and exactly like what Odette had said, we revise it every month. So it's not like you have to rigidly follow what has been done. If you feel that there has been a deviation and there is a solid reason for that, then we do step in and make changes and document that. So it's a process of learning. It goes over a period of time. Also tells you what is not the right way to do it, because someone else is going to learn from that. So it's perfectly acceptable to do that. Though it's a very disciplined approach, it's also flexible. But and that's, I think, the beauty of the A3.
Yeah. Okay. Thank you. Any other questions before we move on? And we'll have time for discussion after each of the next presentations as well. So if you've got something burning, or you have it burning now, then we'll have other opportunity for discussion. And feel free to write in the chat as well. So we'll move on to Dr. Vidya. So Dr. Vidya is Assistant Professor in the Department of Palliative Care at Homi Bhabha Cancer Hospital and Research Centre in Vizag, and is one of the mentors in the PC PACE Equip India project. So we'll hand over to you. Thank you.
Thank you so much. And thank you, Odette, and thank you, Pallium, for arranging this QI project, which I think is very close to everyone's heart, the ones who've done it and been part of the project. In fact, Odette was a mentor for one of our projects too. So I'll just share screen, Rajlakshmi. Yeah.
Ma'am, you are sharing from your end, or?
Yeah, may I share?
You have the access.
Thank you.
Yes, you can.
Thank you. Is that visible to everyone? Yeah, thanks.
Yeah.
So thank you so much, Odette. So over the next 15 minutes, I'll just take you through our project and what we learned from it, and which I hope will motivate many other centers to take it up and do it as part of your regular learning, because that was finally the objective of the QI project. So when we started, for us, A3 was a blank sheet of paper. In 2017, we just looked at it like, we know that it's the A3 size paper, but we didn't know that there was so much to the methodology. And interestingly, this whole methodology has come out of Toyota. So it's a Japanese methodology. And so it was used on the vehicle, and now we were going to use it in medicine. So as an introduction, I'm not going too much into this because Odette has already done this. So this is a very structured approach. The few instructions that were told to us very clearly was, don't skip steps. First, when you have your problem statement, focus on the problem statement. Only once you've zeroed in on your problem statement, then go to the next step. So it was very clear that don't try to rush to the right side of the A3 or skip steps, because that is when we lose focus. So there's also another way, a systematic team approach. The other ways were, we also call it as the plan, do, check, and act cycle. So everything in this is initially planned, then done, then we go back to checking it, and then finally we act on it. And we act on it when we know that this is going to work. And if it's not going to work, maybe we need to take another step back. And the left side, like what Odette has already shown us, tells us about, what is this burning problem that I have brought in? What is my background? What is my goal? What is my current analysis? So the left side tells us about what our current status is. And then we move to the right side, which actually teaches us how to intervene and what we are supposed to do to reach our goals. So this is, Odette has already shown this, so I'll just move on directly to the next one. So this was our team. So way back in 2017, when we started, we thought that, we had a palliative care unit, and it was right at inception at a cancer hospital, which doesn't usually happen at all. So we just had one medical oncology OPD and a palliative care OPD. So it was almost a joke that, of course, you have only these OPDs. So all the patients who have been refused care in all the other centers in the city will now come to you, because there is no other place to go. No one will come to you firsthand. Those are the people who are coming to us. But we took this as a challenge, which has worked very well with us today. We gave them the best palliative care possible. And today patients come to us for treatment because we give them good palliative care alongside treatment and even after treatment. So I think in every challenge, there is an opportunity, and that's what the QI taught us, because this is when we got that phone call and we were invited to the QI program. And we thought that we had just started home care in 2017 with the Vidya project, helping us with a social worker and a nurse. So we had got away. We thought we needed to, we were already working with an NGO. So our home care was rather erratic. So that was the reason why our problem statement was, we are unable to serve patients who need palliative home care the most. Again, when we pick our problem statement, what we were told very clearly was, do not give solutions in your problem statement. So we didn't phrase it as, we cannot provide home care because we don't have a vehicle, or we cannot provide home care because we do not have a staff, because then you're already implying a solution there. So our problem statements, whenever we make a problem statement, we were told to say, just state the statement. We are unable to serve patients who need palliative home care the most, and stop there. And then we go to the background. So what was the background on which we made this statement? We made this statement because we were in the early stages of growth. Our hospital was still young, and palliative care was one of the first OPDs. And we were keen that we preserve continuity of care. Because whatever said and done, I think palliative care, the essence is not just one OPD visit. I think none of us as palliative care physicians will be happy with that. We always wonder, can we look after this patient till they live? And so that's been our motto even today, that we try and look after our patients till they live. So preserving that continuity of care would be possible only with home care. And so we had actually had a triage system. We had divided patients into groups, actually identified patients who need home care, but somehow the visits were very erratic. So that was the reason we picked this problem statement. And then we come to the SMART goal, which is the third step on the left side of the A3. So what was our SMART goal? Our SMART goal was supposed to be specific, measurable, achievable, relevant, and time-bound. So we thought, let us start by increasing the number of visits for patients who need it most to at least 6 per week. We were doing some 2 or 3 a week. So we thought we'll at least increase it to 6 per week by June 2018. So the goal should be realistic. We start the project in September. By the time we identify our problem statement, our background, do our baseline, all of that, it takes another 3 months. So we give ourselves another good 5 or 6 months in which we say is the time that we need to reach this particular goal. So what we thought was that with 6 home care visits, at least we hope to see patients who need home care the most, and then gradually we can increase numbers proportionately and over a period of time. So this was the first phase. So this was how our baseline run chart looked. So what they taught us, which was very important in QI, was have a baseline, and that baseline has to also, so the run charts have to talk like a story. So that's what they always told us, though I don't know whether we managed it every time, but we were always taught your run chart should tell you a story. So my story here was that in the months of November and December, when we looked back to the home cares that we had done, we were plunging somewhere between no home cares in some week to 4 in some weeks to 5 in some week, whereas it was 1 or 2 in the others. So it was this erratic. So this was how our run chart looked. And this was what we wanted to improve. And they also taught us how simple it was to make a run chart, which is of use even today. When we do some of our other work, we can always make a run chart, becomes easier to tell our story. So after that came the most beautiful part of the A3, according to me. I think this is something which we enjoy the most, because we know that we did only so many home visits, but why did we do that? So this was where, and this is what actually came out of the Toyota. It's also interesting to read that story at some point. I think if all of you Google it, it'll be fun to read how many a times when there is a problem, we like to sit on the high seat and say, you do this and you do that and you do that. But the A3 taught us not to do that. So what the A3 taught us was, you do the Gemba walk. And what did we mean by the Gemba walk? It meant that suppose I was sitting in my OPD and planning the home visits, there was a huge story behind that. My referrals came from oncology. They got registered there. Then after that, we assessed them. We put them on follow-up. We had a way to triage them. Then we made telephone contacts. And then we identified who was there for home visit. And then we coordinated with the NGO that we were doing it, and then planned the home visit. So I was not the only person over there who was going to do this home visit. It came through a big chain. And what the A3 taught us was, in the Gemba walk, go to each person. It doesn't matter whether that person was a receptionist or the pharmacist or the nurse or the social worker or the IT person. So we actually went there, told them that this is the project that we're going to do, involved all of them, brainstormed together, and each one brought their problems to the board. And that is how we analyzed it. So in our analysis, we had different ways of analyzing it. Some teams did the Pareto, some teams did the 4-box model, and our team had done the fishbone. So like Odette mentioned, the fishbone, they had given us this broad division, measurements, materials, machines. So what were our problems? We found that, we were not able to make telephonic calls. The check of the medical records was very random. There was no coordination on an everyday basis with the local community home care service that we worked with. And who trained all these people? We were so busy doing our own clinical work that training took a backseat somewhere. And then the network. We had landline phones, and our network problems were there. And more than that, patients shifted. They moved residences. We had one phone contact, but the patient would have actually moved and been living with someone else. Distances. We want to do home care, but how am I going to travel 60 kilometers? How am I going to justify that visit? And who's going to pay for that? And then there were no systematic tools that we had. Though we had a triage, there is still no, objective tool to say this patient needs and this patient doesn't. And of course, personnel, that is a huge challenge which we have even today, is that we are always short-staffed. So putting all this together, we divided our problems into different baskets. And once we did that, we came to what we called as the root causes, and then made the key drivers for which. So we realized that medical records, phone calls, these were all messy. So whom do we go to? So what is the problem? It's the data collection that's a problem. But I don't have a vehicle, my time, my budget. My problem is my resource management. So this is how we take our root cause analysis, and then we make the key. That's how the key drivers come out of the analysis. So when the key drivers came out, we realized that two of our main problems were the data collection and the resource management. So these are two things which are huge factors, which are actually responsible for us not being able to provide home care. So then what did we do? We took each root cause analysis. We had the key drivers. And I said, how am I going to now improve my data collection? I can't do this, but I have the hospital system. They have an electronic medical record. Can I integrate our data into that? So we worked with the IT staff, and they were very, very receptive and happy to do it for us. And so at our end, we worked with the IT staff. At the community level, they worked with volunteers. So both of us managed to create the electronic data system. As the planning went, we did the planning of who needed the home visits. The volunteer in the community, they did the planning as to, the geographical mapping and planning it. And every patient had a unique ID. This was how we addressed each key driver. Even today, I somehow like to remember the key drivers as nouns and the interventions as verbs. It somehow works easier for me, because if I say I need to do data collection, so what am I going to do to achieve this? I am going to create a medical record. I'm going to do something about it. So that's how we mentally divided the key drivers and the interventions which are specific for each key driver. So now we have moved to the right side of the A3. We have come to the top half of the A3, which also gives us another thing that we did then was having a responsible team member. And that team member was not designated as Vidya or Satya or Mohan. It was designated as doctor, nurse, social worker, IT, because tomorrow, even if we do not exist in the hospital, the system shouldn't fall apart. So that was the key in having a responsible team member and the work designation, so that the next person who would come in would automatically follow this and not do it as just a one-off thing. So this was how we sorted the interventions. Now it was time to see if these interventions were working. And so this was what we did. This was how we categorized, created these master lists. And we also, and WhatsApp was very, very useful, because we had our communication through WhatsApp between both the teams. So in the interventions and this coordination, we also took a continuous feedback. So we used to have at least weekly meetings between us and the community. And so which gave us time for feedback, which helped us to know how we were going and what we were doing. And luckily for us at this time, it was really, really lucky that we got a timely grant. And that came from the Two Worlds Cancer Collaboration, and they decided to support our home care. So it was a next level of motivation, because then, the resource management, actually the chunk of the resource management was taken in by this grant by the Two Worlds Cancer Collaborative, and which automatically pushed it to the next level. So now this was how our unchart ran. So this is what we mean by telling them a story. So reading this, I know that somewhere in December, my home care numbers were abysmally low. They were somewhere between 2 and 4. And then after we started this project, they started coming up. The green line was what my target was. And my interventions was to work with the staff and create the system. And the second intervention was to work with the NGO and also get the grant. And then this went on, and we continued this for a good 1.5 years, even after the project, because we used to keep this just to know the ups and downs and what exactly happened. So then we started writing vacation time, public holidays. Those times we started seeing the dips. So this was how our unchart then looked, which was much better than how it looked in the past. But that is not enough, because once the unchart starts running, you need to sustain it. So what was our sustain plan? We decided that, certain responsibilities had to be decided. The people in charge had to be designated. The frequency of everything had to be monitored. And then we only had to get better at that. Because once the basic systems were done, it was on us to prioritize and continue it. So that's how we followed the system. And there is also reliability in this. So it also is like, how reliable are your interventions? Now, if you make a flyer, if you make a folder, if you take one training session, these have to run through multiple plan, do, check, act cycles for it to actually come into implementation, work well. But when you have the system, which is incorporated into your data, so like we had our data collection system, which was incorporated into the EMR, so that worked well in operation. And that's a reliable system because it's always going to be there. The planning, because all of this worked well together, again, that worked well. The other things were in the early implementation and the multiple PDCA cycle. So which meant that these were interventions we had to still work on to make them reliable. Again, we were taught not to make the mistake of having everything into the system, because then if you have a problem, you will not be able to change all of that. So it's perfectly fine to have a mix of interventions, some of which are, incorporated into the system, permanent kind of things, whereas the others are still flexible for us to change as the need grows. So this was how our final A3 then looked. So this was our background statement, which we did over a year. So that was what we were told, don't rush into the last page on the first go step by step. And that's what works best. So now when we went back to the results, we realized we have a dedicated home care team, we have a better organization, a better framework, and more importantly, it gave us the confidence. Because this confidence is that, okay, we came this far, we have our strengths, we are able to network, we are able to coordinate, we can definitely do better. And our staff were also enthused with the project. And most importantly, we learned to take more than 1 or 2 phone numbers. We learned to track patients. We tightened our data collection, and we learned to work with other teams and pooled our resources together. So that's what really, really helped us. Over the years as a mentor, so this was in 2017-18, the story was from then. And then the entire cohort of team leaders, we felt equipped to take on another team. So it was like a nice ripple effect that was happening. So we took on another group of teams. So in 2019, I had the privilege of mentoring JIPMA in 2020 with Adyar. So here the projects were again different. JIPMA was again related to home care, whereas Adyar Cancer Institute took up a project where they wanted to integrate palliative care into their ICUs. And so that again was very interesting because another tool came out of that project. And then gradually after that in 2021, our own hospital has become a QI hub. And we had a very nice project in 2021 with our nursing team, where we were again giving chemotherapy to everyone and anyone who was coming in. but again, there was no structure, there was no appointment system. And so some patients benefited, but most of the patients cribbed all the time. So we put our nurses in charge. They were the team leaders, and that's how we did that project, and which is working perfectly even today. I mean, the project is working really well even today, because all the systems that we formed in 2021 are running very well now. So that was again a good project. And the nice thing was that it's not restricted to palliative care anymore. Today, radiation oncology can talk about QI. Today, nurses talk about QI. So the nice thing is that for QI to grow, it should grow into all aspects of patient care. And it's also nice that our home care program has strengthened. So we have a grant now, and we wrote out a project called Integrated Hospital-Based Continuity of Care, for which we got a grant. So in this, we triage our patients, and those who require home care, we provide them. We also have telephonic contacts. We also have OPD and IPD services for them. And so our data management, our triage is getting tighter, it's getting better. And we also have 2 sets of home care teams. The community home care team also exists. And in parallel, we have one more from the hospital. But the nice thing is that we are not running parallel tracks. We are still coordinating with each other in case of patient needs. So that relationship still continues. So the key learning points, and this is my last slide, is that understanding the A3 way is problem solving. At any point in time, you're sitting and you're looking at, we are looking at quantity, at least in India, we are looking at quantity all the time. And in that, quality suffers. So unless we make a genuine attempt to try and improve our quality, irrespective of the quantity, I think our care cannot touch the next level. And we build a framework, and we do not need much resources, is what the A3 taught us. It taught us to team with teams. It taught us to actually go to ground level and coordinate with everyone who was part of the process, which I think is the most beautiful part of the A3. So I'd be very happy to take any questions later. And a big thank you to Team Stanford, to Equip, to all our partners, to all our coaches, and of course to our patients and caregivers. So thank you so much for this time. And questions as in how you would like it, after the presentations or now, is fine by me. Thank you so much.
Thanks, Dr. Vidya. I think it's fantastic how you really brought the whole process to life, and with some really powerful, tangible running charts and graphs. I also like your mantra, with every challenge there is an opportunity. I think it's a good motto for life, really, but particularly for challenges that might seem intractable or insurmountable, that we embrace them and try and find even the smallest opportunity. We might leave questions until after all the presentations, I think, just in the interest of time, if that's okay. So hold on to your thoughts or write them down. We'll move on to the next presentation from Jaipur, from Dr. Anjum, who is Director at the Department of Anaesthesia and Palliative Care Medicine at the Bhagwan Mahavir Cancer Hospital and Research Centre. Dr. Anjum has a diploma in palliative medicine from Cardiff and was scientific chair of the 2022 Indian Association of Palliative Care Conference this year. So where are you, Dr. Anjum? Over to you. There you are. Good. Thank you. We'll try and, if you can try and stick to 10 or 15 minutes so we've got some time for discussion again, that would be super. Thanks.
Thank you, Rachel. Raju, can you put my slides on, please?
Sure, ma'am. We will share.
Good afternoon, everyone. I really have very little to do because Odette and Vidya have made it so simple. And I like the background that Odette gave for the A3 functioning, and how beautifully Vidya taught us each step of it. I think it makes my task simpler, and we had a smaller project compared to Vidya's. This is my hospital. Can I go into, yeah. Next slide, please. So, our project was based on how well we see our patients in the outpatient in the first visit. And like most palliative care people, we feel that we're not seeing all domains and not doing justice to the person in front of you. So there were issues in documentation, in interventions for social issues, psychological issues, spiritual issues, as well as continuity of care. Like Vidya said, all our hospitals are short-staffed, and we were particularly worried about whether our goals of care were being transmitted to the person who's seeing the patient at night or at 7 a.m. or at 12 midnight. Next slide, please. So our SMART goal was improving our assessment of the first visit, first intake of the patient, so that we at our baseline, like Vidya said, we were seeing that our forms, only 20% of these forms were completed in the first visit. So I'm not going through the A3 like Vidya did. I'm just talking about what our practical goals were. So when we sat down with our whole team, we thought that of these, each person in the first visit, the treating team, the palliative care team, has to finish all these 7 forms in the first visit. So obviously history examination, the PPS, the distress thermometer, nursing social assessment, ESAS, and consent. Next slide, please. So this was a tall order, and I remember Odette telling me that you can't boil the ocean. Odette was one of our coaches, and I was not familiar with that phrase. And I think really, I think Odette was trying to say that it's too big a goal, and you can't possibly boil the ocean, and maybe you could boil a teacup. So Vidya we went through the fishbone to see the root cause of why we weren't filling our forms completely, why we weren't doing a comprehensive assessment. And then we went through the fishbone to form our 2x2. And in the 2x2, I'm not sure you can see that part of the slide, but you divide your, Vidya spoke of the root causes which are responsible for you, which are not allowing you to achieve your goal. So in that, if you divide those causes into the interventions which will have the greatest amount of impact, and you see the amount of effort which goes into that. So you have 2x2, you have 4 squares, and the first square is low-hanging fruit, where you might have to put less effort to achieve a given object. On the other hand, you might have something which will not have too much impact, but might need more effort. So you divide all your root causes into these 4 squares. So as all of us have limited resources, limited time, limited energy. So you need to see which of your goals and how much effort you can put into it to achieve an effect. So the Pareto, like Odette said, in the Pareto, as I understand it, is that 80% of your effort is concentrated or is focused on 20% of your goals to achieve your impact. You can't possibly give the same amount of effort into all your root causes. I mean, practically speaking, from my perspective or from any clinician trying to do QI, you can't give equal attention to all your root causes. You need to prioritize. So you will prioritize depending upon the amount of impact and amount of effort. And again, in the Pareto chart, you will notice, I think, even in your teams, even in any effective functioning team, 80% of your focus is on 20% of the work. And that is effective. Even though it sounds very topsy, it sounds absolutely, it does not sound like as you're planning it well, but that's how it works. I think maybe one of the mentors could explain that better if I've not done that. If, like Odette said in Noah's Ark, discarding the elephants would have made more sense rather than discarding the ants and the rodents and the locusts and the rats and the mice. So concentrating on efforts on things which have an impact. Next slide, please, Raju. So our key driver, our project was simpler compared to Vidya's. So we thought that if we had to have all these 7 forms to be completed, how can we do that? And we thought that we need to, what were the, like Odette said, the key drivers are things that need to be done regularly on a regular basis and standardized way to achieve your object, to achieve your final goal. So the interventions, there could be multiple interventions which will lead to one particular key driver. So for example, if I wanted all the forms to be completed, Aarti and I would need to train multiple people. We need to design easy forms. We might need to delegate tasks or skill share. So if my social worker is not present on a given day, can the nurse take over her task? If my psychologist is not available on a given day, who can skill share? And how can I streamline the whole process how can I make sure that all those 7 forms are filled for each patient? So even the first key driver needed multiple interventions. And Odette explained how the reliability and the person in charge of that particular task was decided so that your intervention was completed. It sounds extremely complex when you're discussing it in this way. I know with them it seems so simple, but the idea, the whole idea, the A3 appealed because all of us want to improve our services. And when you go through it in the systematic way, especially those Jake's videos on Michelle's videos on the 5 whys, on getting to the bottom of why you're not doing something, not making a superficial analysis on I have no time or I'm too overworked, getting to the absolute bottom of why a particular activity wasn't being completed to perfection. So it really helps you to, when you go through those videos that the Stanford videos, really understand where your system is faltering. Next slide, please. So if you make a process map of what I wanted, what we wanted each patient to go through, we were trying to boil the ocean. So we were, your first visit, you wanted nursing assessment, BMI, social assessment, consent, history, distress thermometer, PPS, and examination done, and goals of care charted for each patient in the first visit. Next slide, please. So we ran our run charts, like Vidya explained. Our baseline run chart, only 2.16 of these forms were being completed. Then after our first visit with the first all hands meeting and the energy with that meeting after all our mentors coached us, we the brown line, the green line is our target. The brown is a mean, and we achieved 5.19. Then after our second meeting with more effort and interventions like training, skill sharing, auditing, we reached a higher mean. And as expected, one of our colleagues got married. We had a change in staff, so our targets were not achieved in the third audit. Can I have the next slide, please? So one of the complaints or one of the feedbacks we got, Vidya spoke of the PDCA. So every time you make a change, you see the impact of the change. You see with actually working. You see whether it's doing what you wanted it to do. So when our staff sat down to see those patients and fill all those forms, we've noticed that we were taking 40 minutes for each patient. So that's really not a practical, spending 40 minutes on each patient in a busy OPD is not something we can do in the long run. So again, borrowing from what Dr. Twycross spoke in his book on seeing the patient, the whole patient, and he spoke of seeing the soma, the somatic issues, psychological issues, the social issues, and spiritual issues. So the team decided that instead of having 4 forms filled, if we could design all those into one single form, it will make it more practical and make our goal doable, feasible. Next slide, please. So we made a single form. So we designed a 4S form, and we spoke to many of our mentors, including Nandini and possibly Vidya and Odette, to make a simpler form which could trigger further specialist intervention. So borrowing from the serious health-related suffering tools, we decided, and also because our team found the distress thermometer the most difficult to do. So when we were doing a Pareto, we saw that most times the DT, the distress thermometer, was not filled. Every patient had the history examination done, the nursing assessment done, the goals of care and consent done, but the DT was most commonly missed. And the team members felt the distress thermometer was difficult to do and too time consuming, and they felt that the DT and the history examination had many things which were being repeated. So they felt that in doing the DT, we're missing out on getting close to the patient. On filling the forms, we are not actually building rapport with the patient. So which is destroying the purpose of our QI project. So we changed the form. We did away with DT. We removed DT, and from the triggers for psychologist intervention, social worker intervention, or spiritual counselor were in the simpler 4S form. So that was more practical. So in phase 4, we reached a target of 5.75, and finally we settled on a score of 5.13. The next slide, please. So the process map you see has become much simpler, where we had 7 or 8 steps. With the introduction of the new form, the 4S form, it's become a simpler process. So in the first OPD visit, we had 4S, history, PPS examination, goals of care, and the patient exits. The next slide, please. So like Vidya said, we were able to see what intervention worked. So skill sharing, checklist, fortnightly audit, and the redesigning of the form made a difference in the way we were achieving our goals. The next slide, please. So this is what the PDCA was like. So the brainstorming, cause and effect, 2x2 Pareto analysis. Then we did the skill sharing. We did added the checklists, the team meetings, and the waste walk. We checked with the fortnightly audit, the run charts, and the Pareto. And then we acted by changing the process map, standardizing the forms, and redesigning the 4S. The gateway was sometimes patients left the OPD and they had forgotten to do a particular part. So we added the gateway. I mean, when the patient left the OPD, somebody else was checking the files to see whether he'd gone through all the forms. Next slide, please. Am I going too fast, Vidya? Yes.
Me, it's okay, but I don't know about people hearing it for the first time. I think even I went too fast for that matter, because it's not a concept. That's my
Rachel, am I speaking too fast, Rachel, with my Indian accent?
No, I'm understanding everything. You're going fine.
Okay.
But just a couple more minutes, and then you'll have to wrap it up.
Okay, fine. So then we increased our comprehensive assessment from 20% to 57%, and we were able to sustain that growth. And I think we had better pain management, better patient management, better documentation, and better referrals. The next slide, please. So the sustained plan was in effect, like Vidya said, with different members of the team and different levels of seniority, and your supervisors were also being involved to make sure that what we wanted to do was being checked by somebody senior to us. So that was sustained. Next slide, please. So the additional outcome was we had better overall care. Unfortunately, the way our system is planned is we don't have trained people round the clock. So with our goals of care documentation, we had better out of hours support as well. We had more references to psychology, increased psychosocial interventions. Next slide, please. So I think we moved from that remote doctor who was seeing only the history and examination to somebody who saw the whole patient. Definitely, we learned about A3, which is really a good learning, and I've been able to use that in we are also an NABH hospital. So in our other quality outcomes and projects, it's helping me. We learned about how to sustain it and how a reliable project was designed. Next, please. We were hoping then to do that for inpatient as our next goal. We have not done that. We presented this at the conference in Guwahati. Next slide, please. So this is our whole team. Thank you.
Fantastic. Thanks, Dr. Anjum. Not too fast at all. And I think the beauty of the project and the process itself is that the pictures and the charts just tell so much of the story. I think it's quite amazing how illustrative they are. And I really like your addition of the 2x2 impact versus effort tool. Again, a really tangible illustration of how you can get the biggest bang for your buck, I think. So we'll move on now to Dr. Sunilkumar, who is Additional Director for the Trivandrum Institute of Palliative Sciences in Kerala. Dr. Sunil has a diploma in palliative medicine from India and Cardiff, and a master's in palliative medicine from Cardiff, and was one of the first cohort of the PC PACE program, and has been a mentor in subsequent cohorts. So thank you very much, Dr. Sunil.
Thank you, Rachel. And happy to see many old friends as well as new ones. So I think my job is even simpler than what Audit or Vidya or Anjum did. So thank you, the previous presenters. So I hope it is visible.
Yeah, perfect. Thank you.
So welcome you all to Trivandrum. So this was just a glimpse of Trivandrum. Trivandrum Institute of Palliative Sciences, which is an exclusively palliative care institution, unlike Anjum's or Vidya's institution. So we do only palliative care. And one of our main activity is home care. Every day, 8 to 9 teams goes out for doing home visits. So we wanted to concentrate on the improving the quality of home care. Out of this 8 or 9 home care unit, one of the home care unit is city home care, which concentrate around the institution. And in this city center, we have about 200 patients which need to be catered by a team. The distance they need to cover is about 30 kilometers radius around the institution to cover all these 200 patients. So that made some problems. In addition to the distance, actually the team need to see about 7 or 8 patients per day, or maybe 6 to 8 patients. But in addition to this, there are some patients who calls us urgently, please come and do the needful. We have severe pain. The catheter got dislodged. And even there will be some influential person calling us, come and see urgently this patient. So this makes team very stressed, and they had to stretch their time, and they need to see about 9 to 10 patients per day. So the team felt that they are not providing a quality care to the home care patients. So we thought that we will take this as a quality improvement project. So the problem statement was the city home care team was not satisfied with the quality of care they provided. So our project was title was City Home Care Team Relax, protocols are ready for you. And you can see the team, and we had 2 mentors from Stanford, Dr. Sridhar and Stephanie Herman. As you saw that the home care team is not satisfied with the quality of care they provided. First of all, what we did was we measured the baseline satisfaction score from that city home care team. And you can see that was 5.82 in a scale of 0 to 10, where 0 is not at all satisfied and 10 means the totally satisfied. So the baseline score was 5.82. And what we thought was we will increase the satisfaction score from 5.8 to 7.6. And you saw that before moving into the project as such, we have to make the process chart. So in the SMART goal, actually there are 3 goals. One is outcome goal and the other one is process goal. If you make the process better, then you can make the outcome goal better. So we had 2 process goals. So you know that in palliative care, many patients get registered. Sometimes inappropriate registration would be there. So we thought that by making the registration process appropriate, that will help. So maintain appropriateness of registration process at the present level of 80%. And the home care needs of the patient need to be triaged. So we thought that we did a baseline survey, and it was found that only 33% is the accuracy of triage, which need to be increased to double, that is 66%. But while doing this, we know that when we want to increase the satisfaction for the city home care, then the number of patients that we are going to see might come down. But we thought that there would be a balancing goal, that is to see at least 6 patients per day. So there are 3 types of goals which we did in our project. So this is the baseline score the home care team consists of a doctor and nurse. So this is the combined satisfaction score for doctor and nurse. You can see the baseline score is 5.82. And then we did the fishbone analysis. The fish has a head, which is the problem, and the bones are the causes which can lead on to the problem. So we sat with the team and charted out all the causes which can lead to the problem. And then, sorry. And then, as Anjum told, we did a 2x2 charting where Anjum has described what is 2x2 chart. So I'm not going to explain more about that. Either you can do a 2x2 chart, or you can plot a Pareto chart to see which are the most important causes. If you address those causes, that will lead on to improvement of the quality. So here, the low-hanging fruits on the left-hand side, those were the things which we had to improve. So according to that, we constructed a 4 key drivers, and to achieve those key drivers, we need to have some interventions. So the accuracy of registration and accuracy of triaging process, those were the 2 things which was also included in the key drivers. So we actually need to assign somebody to be responsible to take this each of the interventions forward. So we named people to take each interventions forward, and now you can see that triaging process. Now it is designed in such a way that the patient's needs are grouped into 3. That is whether the patients require high intensity home care, or medium intensity home care, or low intensity home care. This is done using a modified SS score. So we took SS and we removed some items and added some items, and each nurse will ask the patient that symptoms, and the scores will be calculated, and according to that, whether this patient needs high intensity home care, medium intensity home care, or low intensity home care. And another problem was that the home care team which goes out, they continuously receives calls from patients and from colleagues requiring, because the patients need to be seen somewhere else. So this was also causing some distress inside the team. So we thought that we will make a field support team where the calls will come to the field support team, and the field support team will handle these calls. So that was done. And another problem was that the community had a lot of expectation regarding home care, free medicines, money will be provided, and there are many expectations. So we made a brochure indicating that what all can the community expect from the home care team, including home care is not an, it will not be available on an urgent basis. It is a planned visit. And you can see that in April, we did interventions. March, April, we did intervention, and after that, the satisfaction score increased, and the new mean is 7.1, and is going. And you can see at the end, it is touching 7.6, which is the target score. So what are the achievements we had? One of the main problem would be the administration of institution would not be very much in line with the quality. But when we did this project, the administration got sensitized, and they were in line with the quality of the care. That is very important. Especially in an institution where the care is provided free of cost. Then home care team was not very clear what to do in certain situations. So we could provide the clarity on what should be done by the home care team in each and every situation. And as I told you, the institution approved a field support team. And maybe even additional home care team can be actually one team was provided in addition to the existing team to help the to handle the existing load. Then a single phone number was provided to all the patients so that all the calls will come to a center point, and from where it is divided and given to the corresponding team members. And then as you saw, we developed a brochure which actually helped volunteers and the community to understand about home care. So what we learned was when we do a quality improvement project, it is very important to work with the ground level people who are actually working. Then only we understand what are the process involved in a what are the process involved. And I have to say that when I was mentoring a team, actually the doctor who they made a process chart, but when I asked them to sit with the ground staff who actually do the work, and then she told that this is the thing which I did was wrong, and there are many more steps involved. Then only she understood that the correct process, how it is done by the ground level people. So it is very important. And the documentation in each and every step is very important. And another thing is that even though we are the leaders, there will be somebody else who is sponsoring this project, maybe your CEO or your chairman. So you have to talk with your sponsor and find out whether the quality improvement which we are doing is in line with the institution. Because when you reach halfway in the project and the chairman says, no, this is not the way to go forward, then your project will be really in trouble. So that is also very important. Yeah, I think rest are already told. So thank you. That's about the project from Trivandrum Institute of Palliative Sciences. Thank you.
Wonderful. Thank you, Dr. Sunil. I particularly like your project title. I think it's a way to make protocols sound really exciting. City Home Care Relax protocols are ready for you. That was good to get everybody engaged. So we've got a few minutes left at the end. So I'll open it up to all of you if you want to either put in the chat or feel free to raise your hand and speak. Any questions or comments or things you would like to share, or questions of all of the presenters today?
Rachel, if I can jump in, one thing, there have been a couple of questions around identifying patients for home care visits and how often to visit patients. I know that's more specific to the actual clinical care than it is to the QI, but would Sunil or Vidya like to actually comment on how you identify patients for home care, and more detail, or maybe share the details of your triage tool with the participants? Sunil, or would you like to comment?
But I think this is quite institution specific, but because we really, I would love to, know about a tool, but what I do is I have patients as A, B, and C. So the C patients are those on IV chemotherapy who are not going to, whom though I give palliative care, I will not be touching them into any of these interventions. B, we further have divided into B and B plus. So what we do nowadays is in the B, we have patients who are receiving targeted therapies. So those who are on just targeted therapies with a long follow-up of 3 months and more, and who are on the declining trajectory, they will come in our integrated hospital-based continuity of care group. And then when we come to A, those are patients who require home care. Now, the further triage here, I also use the PPS scale and the symptom assessment. So I've created it like that based on their goals of care, along with the PPS and along with the symptom burden. So if the PPS is less than 50 and it's a low symptom burden, less than 40 and it's a low symptom burden, that still qualifies as home care. But if the symptom burden is all above 5 and 6, and they are still in the OMCTs and they're still on therapies, they still classify for home care. So we've made that little thing because that is how it works in our institution.
And was that part of the QI project?
So in the QI, the first time I had made it as A, B, and C.
Right.
So now it has grown into A, B, B plus, and C based on our current.
And do you think that this process helped to really be more systematic? Clearly from Sunil's as well, you developed a triage tool.
Otherwise it can be like, oh, the patient lives here, so I'm going to that area.
Yeah,
that's not the reason.
And each service probably needs to really think about it in terms of service capacity, distance you can travel, staffing, resources, so many factors that are going, as you said, Vidya, specific to each service, how you actually run your home care service.
It's a hospital based, but I think Sunil will have another way which would be nice to hear also.
Okay, so our way of segregating a patient into home care is entirely different because the patients who are coming to us all need palliative care, and we actually provide home care to those patients who are unable to reach our institution or to one of our OPD in the remote centers. So that's the only criteria. Rest, if the patient is bedridden, if the patient is unable to come to OPD due to financial constraints, or if the road condition is very bad, and if the patient has a very foul-smelling ulcer or something like that. So all those are indications for home care. So only if the patient is able to come to OPD, then we will provide care through our outpatient department. Otherwise, all the other patients are seen in home care.
Thank you, Sunil.
Any other questions or comments or things that people might like to share from their own experiences?
I mean, for me, oh, sorry, go ahead, Tara.
Thank you, Odette. I just wanted to say it's so amazing, very inspiring listening to the presentations and the project. I have one question to Dr. Vidya. So looking at your project, I understand that it's a cancer hospital and it's entirely for cancer patients. But I just wanted to know, is there a similar project for patients, other patients, not cancer patients, but non-cancer patients in your region, especially in Andhra Pradesh? Because this project for cancer patients is amazing, but there, I believe, must be many patients with non-cancer conditions, and how is it for them? That's my question to you. And if I continue, my other question is quite personal to Dr. Anjum. When you said about these 7 forms, because touching upon that impeccable assessment for patients is vital in palliative care. And when you said 7 forms to be filled, I fear that when I go back to Bhutan and tell my colleagues that we need to fill 7 patients, they'll send me away to Australia again. But then I'm relieved that when you said you came down to 1 form. And because we will be starting palliative care in India, would you be able to share the form with us where we can modify to our context. Thank you very much.
Thank you for that question. So I'd be happy to say that we actually started home care because through a volunteer, like I mentioned, we have a community project also along with this. So that the goal of that foundation was geriatric and palliative care. So it was definitely for non-cancer and cancer. So the good thing now is from the hospital, it's for cancer patients only, but the foundation, which is in the city, they also follow the process, and that is for cancer and non-cancer patients. So we do run a home care program for non-cancer patients, not through our hospital, but through the center. And we do coordinate between ourselves. So thank you.
Thank you.
Hi, Tara. Very happy to share the form. And it's a very simple form. And I didn't mention one part. One page also has a consent form in it because we are working in a private hospital, and sometimes with very big families, sometimes the documentation is important that the goal intent of care is purely palliative. So we also have a Hindi and English consent form in the forest form. And on the last page is a checklist to see that all those things have been done. All those 7 points have been done. Happy to share it with you.
Thank you very much.
Thanks, Tara. Odette, did you have a question, comment before we?
No, well, my main comment, I think, is the challenge of sustainability. All these projects seem to be sustained, which is a real achievement, because so often that's the hardest part of a QI. Anjum, do you want to?
I cannot say we've sustained it in the way we planned it. So to be honest, so I cannot say that we have 5.17 anymore. So the forest form was made and was initiated, but we've lost 2 more staff. Lost, I mean, we've had changes in staff. So we've had new people joined and they have not got the hang of it. So we don't have that higher rating anymore of our fulfilled forms, but our basic history and the basic form that we're filling has evolved into a more detailed form. So each patient today by default has PPS, BMI, goals of care, consent, and the immediate decision maker caregiver documented in the same form. So I can't say that we're doing that 5.17 anymore, but our basic form has evolved as a result of the QI project. Yeah. And many people have left the hospital and we've not been able to retrain. So we're not doing it as we had planned, honestly.
Yeah, well, that's the reality, isn't it? And that's what makes it a bit discouraging sometimes. Sunil, were you going to say something?
Yeah, I should also say that actually some of the improvements that we brought with some tools like modified SS, practically we found that it is very difficult to sustain. So now we have changed to another system where we group patients into high, medium and low priority. As Anjum told, some of the activities we are unable to sustain, but we still want to keep that's going on so that we find out other methods to do this.
Yeah, no, it's lovely. Thank you.
And I was just going to say that that's like a big part of the quality improvement cycle where you like keep coming back to that like main question, like what is it? What's your statement? And that might be evolving or changing, and then you can change your previous plan and go again and again and again. So don't be disheartened.
But I think often it still ends up coming down to somebody championing it, and it's so hard, you know, to embed these things into systems that then develop a life of their own. But maybe what we've learned is that, you know, the process is also just about as important by forming teams and looking at quality and all agreeing that quality improvement is a really important aim. As much as improving access, we have to keep hoping that there is still incremental benefits, even if our ideal target isn't reached.
Okay. We've just gone a little bit over time. Do we have any final comments from anyone or from any of our presenters? I think, all of the presentations that show that I've agreed that it's really inspiring and quite an exciting process with all of the learnings and things that it does bring up, as Odette said. Odette, did you, or Pallium team, did you want to briefly talk about survey results and topics as well before we wrap up?
Yeah. Sunil, were you going to just make a last comment?
Sorry, I didn't get the answer. There was a disturbance.
Pardon?
I didn't get the question. There was a disturbance.
Oh, I see. I just saw that you unmuted, so I wasn't sure if you were about to make a comment.
What was it? Can you ask again?
Oh, no, it's just if anyone had any final comments before we wrap up.
No, thank you. Thank you.
No problem.
Thanks, Sunil.
I was just a couple of housekeeping at the end. So would the presenters be happy for your presentations to be shared with the participants? Sunil, Anjum and Vidya?
Sure, Odette, I have no problem at all. More than
Just need to delete a patient photograph. I need to delete. That's okay.
I didn't.
Thank you.
Yeah, I'd be happy if someone takes it up.
Yeah,
So
same.
much to do it.
Okay.
Yeah.
And do you, I think there's a new cohort forming for this year. I think applications, are they still open, Vidya, or have they closed?
Actually, Odette, we are now a QI hub at Homi Baba, and I stepped down this year.
Okay.
After 2 years, because it's
There's only so much QI one can take.
yeah, 2017 to 21. So this year I stepped down, but we are doing it in our hospital.
Oh, well
so
done.
I have, so we encourage them here. But I think the selections are done. I'm not too sure though.
Okay.
Can get
So
back.
I guess, how are they advertised? Is it through IAPC?
Yeah, they usually send out and ask for expressions of interest, and then they choose the teams. And now it's running in 2 tracks. It's running in palliative medicine and also in the oncology.
Okay, great.
So because we have mentors from both, like Leela, whom you worked with, Leela is now a mentor with the oncology. So then it works on both ways. So
that's fantastic.
They take in expressions of interest and then they choose the projects.
Okay, beautiful. And we just, for the ECHO program, we did ask for your feedback on new topics. So please send any ideas through to either Raju or to on the WhatsApp group. Where we have a program that goes at this stage through to August. And if you feel that we should have a break of a month, you're welcome to let us know that. Otherwise, at this stage, we're just going to continue rolling on month by month. And the next session on the 10th of May is on methadone and pain management, and Dr. Sunil is again in the hot seat, kindly presenting on the use of methadone from the Indian perspective. And then we have a case from an Australian perspective as well, from Dr. Jess Mather-Hillen, who will be joining us for the first time. So bring your questions about methadone, and we'll look forward to that. Any other last comments, Shri or Raju or Rachel?
I think that brings us to the end of this wonderful session, Dr. Odette. And so thank you everyone for joining us and taking part in such a wonderful discussion. And of course, all the presentations were very enlightening, I would believe. With that note, this is Sri Priya, along with Dr. Odette and other participants, signing off from the TIPS ECHO Hub. See you in the next session with an interesting topic. Till then, everyone, take care, be happy. Bye-bye.
Bye.
Thanks, everyone. Bye-bye.
Bye, everyone. Take care.